Cannabis will likely soon be classified as medicine, but medicine for what? Experts say the DEA's rescheduling of cannabis will be a little bit incoherent. The DEA proposed rules that would officially give cannabis status as medication rather than an illegal narcotic. That's exciting news for researchers, but will rescheduling mean that cannabis could soon move from the dispensary to the drugstore? It's not that simple. Under new rules, cannabis would be reclassified as Schedule III, meaning any cannabis-based medicine would probably require FDA approval and a doctor's prescription. This will mean it will be more regulated than alcohol or tobacco, says Harvard physician Peter Grinspoon, even though it is safer by every metric. Meanwhile, cannabis will continue to be available at state legal dispensaries without the FDA's approval. Grinspoon thinks rescheduling could make it easier to study medical cannabis by easing stigma as well as legal restrictions. Cannabis isn't magically different from everything else, he says. It's less harmful than opiates, but it still has harms. And if you use it, you should want to know the harms. Igor Grant, the psychiatrist and director of the Center for Medical Cannabis Research at UC San Diego, thinks that cannabis could be especially useful for certain conditions that resist existing treatments. Neuropathic pain continues to be an important direction, says Grant. It's associated with many conditions, including HIV, multiple sclerosis, and spinal cord injuries, and is difficult to treat and really impairs quality of life. If you can't sleep at night because of this condition and the meds you're taking are not helpful, that's bad. Johan Marku, author of the book Cannabis Innovations, says that in order to get FDA approval, cannabis-derived drugs would probably either need to be synthetic or extensively refined. There are already FDA-approved medications related to cannabis. Dronabinol contains a synthetic version of THC. Only one cannabis plant-derived drug has been approved by the FDA, that's Epidiolex. Rescheduling could mean the FDA approves similar drugs containing THC, although the agency rarely approves plant-derived drugs. Most drugs that originally came from plants are now made synthetically. Marku says that this type of medication can offer precise dosing and consistency, but will lack the full spectrum of compounds provided by the crude extract. Grinspoon agrees, saying that separating out cannabis compounds hinders the entourage effects. He says that even though AIDS patients have access to FDA-approved synthetic cannabis, many prefer the whole plant. He hopes for a more diverse array of cannabis-derived medicines, not just formulations of its dominant compounds, CBD and THC. Many dispensary owners are worried that rescheduling cannabis to Schedule III will force them out of business. I feel the opposite. Cannabis will eventually be federally legal. If it happens in the next few years or we have to wait another 50 years, it's inevitable. Rescheduling will allow more research on cannabis, but the drugs that develop will never be better than the plant. The FDA currently has trouble approving drugs with variable multi-agent formulations. Synthetic or isolate cannabinoids have already been approved, and yet the consumer continues to use the plant. On the other hand, if cannabis is descheduled, all bets are off. Cannabis would no longer need to be approved by the FDA. All the mom and pop dispensaries would now have competition from big box stores like Walmart and Target. Rescheduling slows down the process and allows state legal dispensaries to retain their market share. What do you think? Could descheduling be a Trojan horse? This is Dr. Jean Talleyrand with High at 9 News.
Dr. T, I got one question for you. So you said that with the rescheduling that they could possibly make make THC available, but they already have Marinol. So why would they make a different synthetic other than what they already have, or allow THC in the first place when they already have a synthetic version already approved?
competition, but yeah, it wouldn't be, and nobody would buy it. They'd be using the plant.
Mm-hmm.
So it doesn't really improve the pharmaceutical market chances of selling products, but it does give the state dispensaries time to sort of anchor into their market share.
I just don't get how any of these state dispensaries would remain open because they wouldn't have that pharmacy designation.
The same way they're open now.
Yeah, but they don't have an enforcement.
A parallel track.
They would have to write that in.
I think this story is not only very timely given the UK stuff that's going on, but it's coming out of The Guardian, which is a UK publication. Follow the money on this one. Yeah.
Fair enough.
But it talks a lot about the U.S. market, which is interesting too.
Yeah.
Dr. Mark, what are your thoughts on this? Because I think this is fascinating, and and I do agree with Professor Grinspoon in the fact that if it goes to Schedule 3, there will be a whole bunch of other research that goes in to actually prove the beneficial effects of cannabis, unlike what we've seen from the results of all these NIDA studies over the years.
That may be an anticipated benefit, but come on, man. Moving a plant that people can grow themselves into Schedule 3 is just a non-starter. There's no other plants that people can grow themselves listed as Schedule 3 drugs, right? Right, and let's face it, Schedule 3 mids from Big Pharma is going to fail miserably. Who's going to buy mids from some, with a Pfizer label on it? Are you fucking kidding me? I mean, I think, well, let me put it this way. I'm all about the admission that there is medical benefit, and that's kind of like the biggest punchline of moving from Schedule 1 to Schedule 3, because Schedule 1 says there's no medical benefit and it's highly likely to be abused, right? So in moving it to Schedule 3, John, the other drugs that are in Schedule 3 are things like what? Ketamine, right, which is synthetic, right? Anabolic steroids, which are synthetic. So everything else in Schedule 3 sounds like a drug, sounds like something you would need a prescription for. Cannabis just is not a drug. It's a medicated, it's a medicinal herb. It needs to be regulated.
That's exactly the point. That's why it's a Trojan horse. That's what I'm saying. It delays things, essentially. It's going to go nowhere. I think we completely agree with you here. It's going to go nowhere. But that's what you want it to do, go nowhere, so that the current dispensaries get entrenched into their market there and not get taken over by big pharma.
The good old road to nowhere.
Couldn't the wild card here be that now, if it does go into Schedule 3, and that's clearly the realm of FDA-approved pharmaceutical companies, that now somebody who's got a lot of lobbying power in D.C. can start putting pressure on the regulatory agencies to shut down the rest of the market, right? So it's like if the Schedule 3 people want to do this, they need to somehow protect their market. How would they protect their market? They would basically get rid of Rohr Farbacher, get rid of, basically end the state regulated programs as we know it, so they can protect their investment. Because I think what could happen, Jason, is that all the MSOs who are close to being GMP in terms of their level of production,
GMP certified, yep.
Those. So ultimately, an herbal product like this has to be made in GMP. It has to be tested by GLP, all that kind of stuff. That's just a financial hurdle that most cannabis companies just cannot get up to. But, you think about it, a pharmaceutical company who's already got all that in place, can they come in and retroactively kind of establish those types of GMP type practices at large scale cannabis manufacturers like the MSOs, so the Curaleafs and the whatever, the MSOs, right? So I don't know. I mean, I would think that the one other wild card here is that, they always talk about synthetic, like Jean just talked about, synthetic cannabis. There's no synthetic cannabis, right? It's synthetic cannabinoids, right? And it's kind of like now you're talking about that hemp market, right? Where everyone's turning CBD and any other chemical that you could extract from legal hemp, turning it into a psychoactive product. So, yeah, I mean, there's sort of different forces and different headwinds to see, how this thing could possibly shake out. But Jean, going back to, again, like the doctor's point of view. And so like a lot of doctors, you're unlike a lot of doctors, but a lot of doctors say, well, we want to see the data and we want to understand dosing and we want to understand this before they write a prescription. Is all that in place now? I mean, could we convince those medical doctors, not people like you, but medical doctors who maybe have been reluctant to prescribe cannabis because they're essentially drones of big pharma, right? And they end up just, here, take Skyrizi, take Ubizi, take this, take all these other drugs with all these litany of side effects.
Stupid.
I mean, how do you change that population?
You think Skyrizi is a stupid
like
name?
Jean?
Remember, doctors prescribe cannabinoids. They don't prescribe cannabis. They prescribe cannabinoids. So is that going to change and they're going to start prescribing cannabis all of a sudden? No, it's a paradigm shift. You've got to send them all back to medical school, teach them about plant biology and how to prescribe herbal plants and get them to do that. This is too huge of a turnaround for doctors. Right. So they will always prescribe cannabinoids, but people are not using the cannabinoids. They're using the cannabis. They're using the plant. And so this is why it's just going to be a failed attempt. Let them go, though. It's just going to take them time, and it's going to give the cannabis-selling state-legalized dispensaries more time to get entrenched and develop their market.
Dr. T.
Trojan horse.
What schedule is Marinol? Is that a Schedule 3 drug currently?
Yeah.
It is?
Yeah.
Okay. All right.
I mean, I don't think that a reschedule is going to be a remedy for something that shouldn't have been scheduled. Like, it was scheduled inappropriately to begin with. So I think that this is protectionism, looking at FDA preclusion, looking at things like the 9/11 patents that came out to combat GW Pharmaceuticals' Epidiolex patent that patented cannabinoids in an aqueous suspension. It was a formulary patent, essentially, that covered 90% or lower, and then ours came in and had 90% or higher, anything derived thereof. That didn't just say hemp-derived cannabinoids. That's a cannabinoid-based patent, and I think that everybody should probably look that up and read into what that would mean, because at that point, GW was trying to come in and say, hey, listen, they're recognizing Epidiolex. You guys now won't be able to make anything. And so we came in as the industry created this patent, encompassed theirs, and then unfortunately business went as business goes sometimes. And but that passed the Alice test. So I think we need to be very careful.
Yeah. So if we could find if we could find an attorney with a set of cojones who's maybe can be self-funded here, we can challenge that patent in a court of law, because there's basically prior art that basically predates that patent to say exactly what that patent says. So I think that, I don't think there's any precedent on challenging cannabis patents like that. But I think it would be something that, if another big pharmaceutical company wanted to do it, they can do it.
Yeah, no, 100%.
You got to remember now. So Jazz now owns GW, right? GW, I don't think, is no longer a company, right? I think, right? Isn't it Jazz Pharmaceutical? In fact, on the label of Epidiolex, it doesn't say GW anymore. I think it says Jazz.
Yeah, this
right?
is Jazz.
I haven't checked. Yeah.
And their patent definitely did.
Yeah. So now you're.
Go ahead. Sorry.
Yeah. Now you're dealing with a multi-billion-dollar pharmaceutical company with an army of lawyers. So yeah. Good luck.
Yeah, that's
going
gonna
to sit down on a cannabis. Go ahead.
It was interesting because it was a private attorney. It was our internal general counsel. I'm going to send it to you because it's interesting, and they actually we'll talk about it, not publicly because of yeah, well, I don't want to get in any trouble. Nobody sue me. But I think that it's interesting to see the industry kind of stand up and say, no, we're going to protect what we've built. We're going to protect our patients, and we're going to protect best interests.
Fair enough. And
Give people their medicine, damn it.
And on that, we're going to roll into a commercial.